Hi everyone, welcome to lecture 5 where we're going to talk about aggressive and self-injurious behavior. The information from this lecture comes from the supplemental text, chapters 5 and 6. If you decided not to buy that book, there are PDF copies of those chapters uploaded online so you can reference them. So we're going to start talking about aggressive and self-injurious behavior. The reason that we are going to talk about this is because aggressive behavior is often cited as the most prevalent of such problem behaviors seen in individuals with intellectual disability. In the last lecture, I talked about what problem behavior was and the difference between that and adaptive behavior. I want to really note that if we're saying that aggressive behavior is often cited as the most prevalent of problem behaviors seen with intellectual disability, it's really important to note that most people with intellectual disability are generally not aggressive. We usually see aggressive behavior crop up when we see difficulties in adaptive behavior that aren't being met, or there's some other problems that aren't being addressed. But it is something to consider because we do see aggressive behavior in this population, and it's the most common problem behavior seen. But again, this population is not aggressive or dangerous generally. And so I really want to make sure that that's an important distinction to make. So I want you to think for a second what you think aggressive behavior is. So if someone said someone's being aggressive, what is it? It's important to understand what it is so we know what we're talking about, because that term can apply to a lot of things. And when we're talking about aggressive behavior in this context, we're talking about hitting, kicking, spitting, biting, any verbal aggression that can be accompanied by nonverbal threatening behaviors. All right. So here, looking at the prevalence and risk factors. So aggressive behavior does occur in up to 42% of individuals with intellectual disability, making it, again, the most common or aggressive behavior or problem behavior that we see in this populations. It occurs more in residential settings than community settings. Your chapter talks a little bit about that, but I think it's important to pause and think why that may be. It occurs more in individuals that have more severe presentations of intellectual disability rather than mild, more so in males than females, and those that have an autism spectrum disorder diagnosis in addition to intellectual disability. When we start Module 2, we'll talk about autism spectrum disorder and as it relates to intellectual disability. The two are commonly thought to co-occur, and that's not the case. Most people with an autism spectrum disorder do not have an intellectual disability, but if they do have both, we can see more aggressive behaviors. Also, the level of receptive and expressive language. So if we have deficits in those areas, you could think why you might see some more aggressive behavior occurring. Age, usually around 20 to 35 years of age is when we see the most occurrence of aggressive behavior. Additionally, if an individual has a history of anger and violence, that puts them at higher risk for having aggressive behavior. Psychopathology, so co-occurring difficulties with mental health, specifically depression, and also if they have a history of being abused. What will happen then is that we'll also see a higher risk of aggressive behaviors later on. So when we're looking at how do we address aggressive behavior through an evidence-based practice model, and if you remember back from the second part of the first lecture, kind of talked about the importance of evidence-based practice, which this supplemental text really highlights. It's important to look at this through seeing why the behavior is happening. And we do that by looking at antecedents, behaviors, and consequences of the aggressive behavior. So antecedents are things that occur directly before we see the behavior. This can be setting events, situational events, time of day, the mental state of the person, the activity they may be engaged in. It's important to consider those things so maybe we can manipulate or change those things so we see a possible decrease in aggressive behavior. Then we also want to look at the behavior itself. What does it actually look like? Is it hitting, kicking, spitting, punching? What's the intensity and the severity of the behavior? And then consequences. So consequences, that term can be a little bit confusing because it might assume, well, then you have to do something. Consequences are just anything that happens directly after the behavior. That could be nothing. So a consequence could be nothing. And it's important to look at behavior in general through a functional behavioral approach by looking at behavior as having three parts. Anything we do, including maladaptive behaviors, which for the purposes of this lecture, we're talking about aggressive behaviors, occurs in three parts. So anything we do throughout the day has something occurs, you exhibit a behavior, and then something will happen right after. And if we have a good understanding of these antecedents and consequences, again, we can use those to our advantage to start determine what the function of the behavior might be. Is it because they want to escape something? Is it because they want or something or someone? Is it because they want access to something or someone? Is it because they're trying to avoid or seek out some certain sensory input? But once we start getting a really good understanding of why the aggressive behavior is happening, by looking at the antecedents and consequences, we can really start help tailor interventions that can that'll work. So how is a functional behavioral assessment done? This is done through observations, multiple observations across multiple times of the day when you're seeing the behavior, and then also when you're not. If you also observe when they're not seeing the behavior, you can see what things are going on antecedent and consequence-wise that are maintaining appropriate or adaptive behavior. Interviews with people that the individual interacts with. This could be teachers, parents, other caregivers or family members. There are various rating scales out there to help augment this and make it a very helpful assessment approach. Reinforcement inventory. This is done with the individual. So we all have certain things that we're willing to work for, right? And those might differ from person to person. So really getting a sense of what the person values and what they're willing to do and what they're willing to work for, because what might work for one person isn't going to work for another. So say, for example, like for me, for example, if we're looking at tangibles or edibles as a reinforcer, I don't really like chocolate. I mean, I like it just fine, but if I was having difficulty doing something or wanted to stop something that someone wanted me to do, if they said, if you don't do this, then you'll get this, which would be a piece of chocolate, that might not be very motivating for me. But if you said, if you don't show aggressive behavior and I'll give you a French fry, then I'd be all about it because I really like French fries. So if you do a reinforcement inventory with the person, you're more likely to be able to match reinforcers, whether they're tangible, edible, or more social in nature, match them to them so they're willing to work for it. And then additionally, you start to manipulate consequences. And this is really experimental. So you start trying to change some of those things that happen afterwards and seeing, maybe if you think the function of something is for attention for a certain individual, well, let's start giving that individual more attention when they're not showing aggressive behavior or removing attention when they show aggressive behavior. Maybe it works, maybe it doesn't, but that helps to give you some information about what the consequences or things that are happening after that might be maintaining the behavior are, and then you can have a bigger chance of success with your intervention to address aggressive behavior. So what does the literature say? So what are the evidence-based practices for addressing aggressive behavior in individuals with intellectual disability? So first and foremost, again, behavioral interventions, and these are function-based antecedent interventions. Remember, antecedents are those things that occur right before a behavior. Antecedent manipulation and changes in context just alone is not sufficient. Really, again, we're going to look at a mixed treatment package when we're looking at behavioral interventions. Function-based reinforcement, non-contingent reinforcement, which means just providing people reinforcement all the time, currently lacks sufficient evidence alone. But when we look at everything as a whole, as a mixed treatment, so looking at antecedents, looking at contingent and non-contingent reinforcement and various reinforcement schedules, when those things are taken as a whole, that is an evidence-based intervention for aggressive behavior. So that's the take-home message here, is that we're looking at a mixed treatment package, so multiple behavioral interventions, not just one alone, is sufficient at decreasing aggressive behavior. So remember that. All right, additionally, let's look at some other stuff. So non-function-based interventions, so differential reinforcement schedules are considered an evidence-based intervention. Differential reinforcement means just changing the timing. Again, this is a little bit overly simplistic, so you can get more information from the readings, but just changing up the reinforcement schedule to either smaller or larger intervals. That is shown to be an evidence-based intervention. Antecedent exercise. It's currently lacking sufficient evidence. Response blocking, also lacking sufficient evidence. Contingent positive punishment lacks sufficient evidence. Should note that positive punishment doesn't mean good punishment. Positive just means you're adding something to the environment, so adding something that would be punishing. When we're looking at skills training interventions, functional communication training is considered an evidence-based intervention, especially when it's used with behaviorism practices as well. And currently self-monitoring is lacking sufficient evidence for decreasing aggressive behavior. So there we go. All right. Cognitive behavioral therapy is currently inconclusive. Other treatments such as mindfulness, the teaching family model, vibroacoustic music, and aromatherapy currently do not have an evidence base for decreasing aggressive behavior in individuals with intellectual disability. Doesn't have enough, doesn't mean eventually it might not be, but right now there's just not enough evidence to support it. And remember, when I was talking in chapter 1, if there is an evidence-based, or rather, I was talking in the second part of lecture 1, if there is an evidence-based treatment available, it's important that we employ those practices. If there's not, then it's okay to kind of use some other things. But in this case, right now, these things don't have sufficient evidence, so it's best to just adhere to evidence-based practice. All right, now we're going to talk about a different type of aggressive behavior, specifically self-injurious behavior. So this is deliberate harm to one's own body. And examples of this, and this list is not exclusive, or all-inclusive rather, just some examples: skin picking, head punching or slapping, poking in the eyes, biting self, pulling hair out, cutting self, and self-induced vomiting. But again, the main thing here is that when you're looking at someone trying to hurt themselves as opposed to someone else, and it's anything that would typically cause like serious bodily injury or tissue damage to themselves. Some risk factors for self-injurious behavior in individuals with intellectual disability. Again, institutional versus community settings. So again, individuals that live in institutions are at a higher risk for self-injurious behaviors. Certain genetic syndromes, which we'll talk a little bit more about in Module 3, so specifically Prader-Willi and Lesch-Nyhan. Those genetic conditions, you do see a higher rate of self-injurious behavior with intellectual disability in those types of syndromes. Comorbid conditions, so having autism spectrum disorder and intellectual disability. In addition, if there's any hearing or vision impairments and intellectual disability, we do see that population having more self-injurious behavior. Age, around 2 to 3 years of age is usually when you'll start to see self-injurious behavior in individuals with intellectual disability if it does occur. And then it can become more frequent and severe throughout childhood. And then with more severe levels of intellectual and adaptive functioning deficits, that's a risk factor for self-injurious behavior. All right, I think it's important here just to point out the negative impact and financial costs that self-injurious behavior has on the individual and their family. So individuals with intellectual disability that engage in self-injurious behavior, they have a higher risk, obviously, of injury, and some pretty bad injury and long-term trauma from being exposed to their own self-inflicted injury. So there'll be more hospitalizations and doctor visits and emergency medical costs, which are really, really large. Higher rates of institutionalization for individuals with intellectual disability and self-injurious behaviors. And then the amount of parent and family stress. If you can kind of just take a second to think about how stressful it would be for the family unit to have a member or a child that's engaging in self-injurious behavior, how just emotionally distressing that could be to watch your child or your family member engage in that behavior. And then just an overall decrease in quality of life for the individual that's engaging in self-injurious behavior, because they won't be able, they will, they're inflicting pain upon themselves, and then also, they're not able to participate in activities as often as individuals that don't. And going back just to the cost of this in general, it's estimated that individuals that engage in repetitive severe self-injurious behavior over time can cost a family up to about $100,000 a year when you kind of look at all these things together. There's a huge financial cost. So effective treatments for individuals that are showing self-injurious behavior. So applied behavioral analysis. Again, this is kind of a common theme you'll see. And that can be done through functional communication training, non-contingent reinforcement, and function-based extinction. Behavior modification principles such as differential reinforcement schedules, punishment. And this is where usually punishment is never our first line of defense, but in this population, when they're showing this behavior, this is an evidence-based treatment, but it should always be used within a full ABA or behavior modification package. And then contingent restraint of the individual and putting protective equipment on them. So what are some things that are lacking sufficient evidence? Again, doesn't say that maybe these things won't be someday, but right now they lack sufficient evidence for decreasing self-injurious behavior. Cognitive behavioral therapy, the use of weighted vests and gentle teaching, electroconvulsive therapy, snozzle in rooms, which the chapter will kind of talk about essentially is like this room with all these different sensory experiences in it, transcutaneous electric nerve stimulation, exercise, and room management, so just changing the setting of the room. So again, it's important that we look our first line of defense, since there are effective evidence-based treatments, we use these things first. Because remember, that's what we want to do if we do have available evidence-based treatments. And maybe some of these things someday will show to have an evidence-based as well. They're just currently lacking sufficient evidence. We do have 2 treatments that are shown to be ineffective, so not making things better, and in some cases making things worse. And those are auditory integration and sensory integration therapies for self-injurious behavior specifically. So important that you understand those as well, so you have knowledge of that. All right, so that kind of wraps up aggressive and self-injurious behaviors. Again, read those additional chapters if you would like to. It kind of goes a little more into depth with some of these things, but this is kind of an overview or highlights of the information from there. But again, just want to remember that while aggressive behavior is the most common behavior that we see in individuals with intellectual disability, or rather problem behavior, the most common problem behavior, it does not mean that people with intellectual disabilities are dangerous in nature. Have a great day, everyone.